Hello, welcome to No Health Without Mental Health, a conversation with mental health leaders during this Mental Health Awareness Month. Today, we plan to talk about many issues that keep people from getting the mental health care they need and deserve. I'm Hannah Wesolowski, Chief Advocacy Officer at NAMI, the nation's largest mental health organization. I'm honored to be joined by the Honorable Lisa Gomez, Assistant Secretary for Employee Benefits Security at the Department of Labor, Dan Gillison, CEO of NAMI, former Representative Patrick Kennedy, who's the founder of Kennedy Forum, and former Congressman for Rhode Island's 1st Congressional District and a leader of the 2008 Parity Bill, which we'll talk about today, and David Lloyd, Chief Policy Officer at Inseparable. We know far too many people with mental health and substance use conditions struggle with getting parity in their mental health care. We know that too many people still get denied coverage, struggle to find a mental health care provider in their insurance network, and often have to pay out of pocket. Today, we're going to dig into a lot of these topics, but first, let's meet our speakers. Assistant Secretary Gomez, I'm going to turn it over to you first. If you can tell us a little bit about yourself and your organization and why you're passionate about this topic.
Sure. Thanks so much, Hannah. Really grateful and happy to be here today. I have the honor and privilege of serving as the Assistant Secretary of the Employee Benefit Security Administration, which is an agency within the United States Department of Labor. And I've served in this position since October of 2022. And what the Employee Benefit Security Administration does is our mission is to protect the hard-earned workplace-based benefits, retirement and health benefits of America's workers and their families. And one of our main priorities is to protect their mental health benefits, their rights to mental health and benefits for mental health and substance use disorder conditions. This has been a large part of what we've been focused on, what I've been focused on since the minute I walked in the door there. I think Patrick may have been one of the first people that I met on the job. So if that goes to show you how high of a priority mental health parity is for me and for this organization, that's just one sign. And we work on regulations, participant assistance, compliance assistance, enforcement, and sort of all aspects of benefits, covering more than 150 million people across the country. So I'm very proud to be here, very happy to serve in this position, but thanks.
Thank you so much, and thank you for the incredible work that you and the administration are doing around this issue. Dan, I'm going to go over to you next.
Thank you, Hannah, and Assistant Secretary Gomez. Thank you, and we appreciate this opportunity today and appreciate your leadership. That's the first thing. Leadership is so critically important. The tone that you're setting and then how you're executing is so critically important. Who NAMI is to this conversation is a 45-year organization, the largest grassroots mental health organization in the U.S. that really focuses on lived experience. We are the voice of lived experience. We like to say we're the DNA in the communities across the country with over 650 affiliates in 49 state organizations. Many of our people have taken their personal pain and turned it into purpose. That purpose has become their passion. And I'm sorry for all the P's, but passion is incredibly powerful when it's harnessed. And that's who we are. That's what we do. And that's what we do from an advocacy standpoint. That's what we do from a programming standpoint. And this conversation is so important in the month of May when we have so many young people graduating from college. What does mental health look like for them? What does access to mental health look like for them? So we're really excited to be having this conversation. And thank you for setting the stage for us. Hannah?
Thanks so much, Dan. And Congressman Kennedy, I would love to hear a little bit about the Kennedy Forum and why you're so passionate about this work.
Well, thanks, Hannah, and big shout out to NAMI and Dan for your leadership. The work of NAMI makes such an impact on mental health policy. I've been honored to work with you for years and love the fact that you come from the county perspective, Dan, having been executive director of the counties. So much of this has to do with, unfortunately, our justice system. And NAMI's really been at the forefront of trying to change from us having a country based upon jails and prisons being the largest provider of mental health services to community-based care. And that was the original vision of President Kennedy, was to create a community mental health system. Tragically, he was killed and he never saw to see this vision realized. But now we're starting to move in that direction thanks to the Biden administration, the Certified Community Behavioral Health centers and building back a community model that includes clubhouses, it includes supportive housing, frankly, things that we don't pay for in our medical insurance system. But thanks to Secretary Gomez and others, if we can get this parity fully enforced, then payers are going to have to come to the table, because there's nothing like a little pressure, a little liability to make them want to finally discuss this. If they're going to be in trouble if they don't address this crisis, then they're going to be asking us, finally, what do we need? And we need services. We need access. And that's what, you know, obviously EPSA and Secretary Gomez are fighting for us to get through more enforcement. And you know, you can tell where my priorities were, Secretary Gomez, because I wanted to see you right away, because for most people, they're asking themselves, what's EPSA got to do with it? And love that Tina Turner line. Thank you for that. But it's really where the action is. It's where the rubber meets the road, enforcement. And that's our job in DC. And I'll pass it over to David Lloyd, because you know, the parity enforcement has been a big part of our mission. And David, you've been a big part of helping us advance that. So I'll turn it over to you.
Thank you, Patrick. Appreciate being here today, and thank you to Assistant Secretary Gomez. The staff at EPSA really has done tremendous work in increasing access to mental health coverage, particularly through the Federal Parity Act, which I have worked very closely with the Kennedy Forum and with Patrick over the years, and now at Inseparable continue to partner very closely with the Kennedy Forum and NAMI on these fundamental issues of increasing access to services, so we can really address the mental health and addiction crisis that is ongoing in our country. So I am now Chief Policy Officer at Inseparable, and we're a mental health advocacy organization that's focused on building a social movement to really win major federal and state reforms that will save lives and improve care for millions of Americans. And access is absolutely critical to that. Without access, you can't have mental health. And health insurance coverage is critical to access, because if we don't have health insurance coverage, that people's plans are paying for the services that they need, then access is really a mirage that we'll never really realize. So it's critical that EPSA's work is critical. It's critical that advocates like NAMI and the Kennedy Forum and Inseparable work together to finally make parity a reality and build this foundational piece to make sure that we're financing a mental health and addiction system that our country needs. So thrilled to be here and excited for the conversation.
Thank you, David, and thank you all. David is such an expert and leader in this space and working with all of our groups to make sure that we continue to improve parity and access across the country. So thrilled to have you all. And to start things off, let's level set a little bit. So Dan, I'm going to kick the first question over to you. May is Mental Health Month, and as we start this month, could you talk a little bit about the state of mental health in this country? Where are we? How are we doing?
We're in a new place from the standpoint of the conversation. There was a period of time when we were trying to get seats at the table. Now we're at the table. The question is, how do we execute and how do we move the needle from the standpoint of access to care? People are struggling. What we're seeing across the country, just from the standpoint of young people and suicide in terms of the metrics, and parents being able to access care for their young people and young adults. So there is quite a bit that's going on from the standpoint of access to care. And then we have communities who were already in situations where, from the standpoint of stigma, would not access the care. So now, as we look at it from the standpoint of wanting to be able to access that care, there's still, that real challenge. And if we think about suicide, there's a couple of things I'd like to share very quickly so we can have this conversation. Think about this from the standpoint of what David said about health. And there is no physical health without mental health. Nearly 2 out of 3 female high school students experience persistent feelings of sadness or hopelessness during the past year. 2 out of 3. 10% of high school students attempted suicide in 2021, including 13% of female students and 22% of LGBTQ+ students. Black or African American individuals between 10 and 24 years old saw the largest proportional increase in suicide rates between 2018 and 2021. We have a situation where we have folks that are feeling hopeless and they're struggling, and we need them to feel hopeful. And part of this is addressing access to care and stigma. So that's where we are, and I think that we're doing a number of things to address it. The National Strategy for Suicide Prevention was just introduced. We have the Reimagined Crisis Response and looking at really making 988 pervasive across the United States. So we're accessing a new platform for care. So there are some things that we need to do more of, but that's the state of mental health as we see it right now.
Thanks, Dan.
Mm-hmm.
And Assistant Secretary Gomez, I'm going to go over to you next to hear what are your priorities during this mental health month? What's a top of mind for you and DOL?
Thanks, Hannah. And thanks, Dan, for your really powerful words and those statistics. As much as we hear them over and over again, they're still jarring to hear. My priorities, I guess I'll start with that this is a real personal issue to me. This is not just an issue that I happen to come into being into this position. I think that there's unfortunately so few people who can say that this is not a personal issue for them, whether they have dealt with mental health or substance use disorder conditions themselves personally, family members, friends, coworkers. It's everywhere. You can't escape it on a day-to-day basis. It's always there. I was sharing with some of the folks on this group before we started talking that one of my kids just graduated from college this weekend. And I was really pleased to hear that one of the cords that some of them were wearing, when my child told me that they were green cords to show people who had gone to therapists for mental health, but then was struck to find out that it was kind of a secret code, who had gone to mental health. And so that really gets to what my priority is to just stop the stigma with this, because the stigma is really holding back so much of how people can get treatment, get access to treatment, and just in what I've seen of how health coverage providers are approaching this is just from such a different place, a place of stigma. We have to just stop reinforcing that there's this stigma attached to mental health conditions and to substance use disorders. It should not be any different for a person to call into work and say, I need to take a day off because my brain needs a break. Not just that I have a sore throat or, I have congestion, but my brain needs a rest. It shouldn't be any different for someone to talk about having an eating disorder than it is to talk about having diabetes or some other condition that affects the way you eat. It shouldn't be any different to say that you need to go get therapy for a behavioral health condition than it is to say that you need to get therapy because your knee hurts from time to time. But it is. It shouldn't be any different, but it is. And it's also different, not just in how communities, people, friends, approach this, but also, and really importantly, in how the health plan system, the health coverage system approaches this, because we can't escape it. I mean, they look differently at people who are coming in with these types of conditions than they do with people who are coming in for medical and surgical conditions to be treated. And over the past year and a half that I've been here, I've heard time and time again, health plans and health plan representatives come in and say that mental health parity is the most important thing to them, but they need to be showing by their actions and not by their words. And so that is a top priority to me. And so we are continuing to work on regulations and to try to get to, as David and Patrick and all of you mentioned, to find ways to be able to better enforce these laws and stronger laws. And we are also working very, very hard on outreach, so that Patrick likes my joke that I came up with at one of his sessions, but what's EBSA got to do with it? As much as I joke about it, it's really sad to know that we are here to serve over 150 million people in this country, parents, like you say, who need help. And we're just a phone call away. And coming from a parent who has herself called, the hotlines and, numbers for help, to not know that there's a number out there where someone can so easily try to connect you and fight for you to get that coverage. That is just, if I don't accomplish anything else while I'm here, if I can just get some people to say, oh, EBSA, no, I heard of them, I called them and they helped me, that's really all that matters to me.
And let me follow up on that. If somebody is struggling to get that coverage, has questions, where should they reach out? What should they do?
So thank you for that. I had struggles with this number at some point because I wondered if I would ever really commit it to memory, but now I feel like I will never forget this number. But we have a phone number. It's 1-866-444-3272. And those last four numbers stand for EBSA. So if you remember EBSA, you're at least 4 digits into the number. So you can call that number. You can reach us online at askebsa.dol.gov. And if you just get yourself to the dol.gov website, the Department of Labor website, and you type in mental health parity, you'll get to us. But that first phone number is the best one to reach. And we have benefits advisors across the country who speak multiple languages, including the language of health plan coverage, which can be sometimes the most difficult language to translate, and who can really help and lead you and get you the care that you need.
Thank you for that. We will all make sure, and I hope everyone watching this will make sure that they get that number and that website out there for others to be able to get that support that's available, and yet so few know about it. So we will all contribute to that effort. David, I'm going to go to you next. You've been doing advocacy in this space for a long time, and I'd love to hear what Inseparable is prioritizing right now and doing with Mental Health Month, and really where you see the state of mental health in this country.
Yeah, so Inseparable, we're really working with our partners to ensure access to care, really through accountability. And a critical component of accountability is mental health parity. So along with partners like NAMI and the Kennedy Forum, we're supporting finalization of strong rules to the Parity Act, which EBSA, we're grateful, put forward last year. And these proposed rules really have the potential to be game-changing when they are finalized, and will finally bring long overdue accountability for when plans limit access to mental health and addiction care in a way that is simply not the case for physical health care. And one of the things we hear a lot is there's a lot of talk about provider shortages, and indeed we need more providers. But there is a big gap between in-network availability of mental health care versus physical health care. And there was a report just released by the nonprofit research firm RTI that really lays this bare, that shows that for behavioral health, out-of-network coverage occurs 8, 10, even 20 times more often than out-of-network care occurs for physical health. And this care is care that is actually being provided. It's being provided by providers who exist. It's just that the individuals cannot find that care in insurers' networks. And so the result is really high cost to consumers, and they're forced to self-ration care in a way that is simply unacceptable, and often has devastating consequences when people don't get the care they need. And we cannot allow health plans to take premiums, and frankly also money from taxpayers, and then be withholding reimbursement for the services that people need. And so that's why these final parity regulations are so important, and we're so grateful for all the work that has been done. And then finally, I'll just note that the RTI report also includes a lot of data on reimbursement rates, which is why the networks are really inadequate in a lot of ways. That insurers are paying behavioral health providers more than 20% less on average than physical health care providers when Medicare is used as the benchmark. And even if you look at physician assistants for physical health, are actually paid more for the same codes than psychiatrists. And psychiatrists, have a significant amount more training. So the gaps are really stark. And the excuse that just saying, oh, there's a provider shortage, it's simply not true that that's a driver of inadequate in-network access. There are more than 25% more primary care shortage areas than there are mental health care shortage areas, according to federal data. yet only 2.2% of primary care is out of network, yet more than 15% of psychologists and psychiatrist visits are out of network. So, we can no longer accept the excuses, and we have to bring accountability, and the final parity banks are critical to that.
Thank you for that, David. I think you set it up perfectly because we can now transition into more discussion around parity specifically. What the parity bill is, what we dream for it to be, where we are now, and what we're trying to do to improve parity in the future. So, Congressman, I'm going to go to you because while you were in Congress, you really led efforts to pass the Mental Health Parity and Addiction Equity Act. And now we are, last year we marked 15 years since that bill passed. Could you talk a little bit about the genesis of that bill, what it took to get it across the finish line? Really want to hear what your dreams were for it and how are we doing today? Where are we?
Well, thanks, Hannah. I think to cut right to the chase, we're at the most important point in the last 15 years on the parity law, which may bewilder people who are listening to this. But as we speak, Secretary Gomez's recommendations are being vetted by the Biden administration to put forth, as David just said, on a parity enforcement rule that will begin to pay providers on par, hence parity, what we pay other physical health specialties. And the whole idea of parity is equality. So if you cover chronic illnesses like diabetes and cardiovascular disease, if you screen early for cancer, why aren't we doing all of this with mental health and addiction? Why are we waiting till people have a crisis before they get treatment? Why are we accepting that people have to go out of network, as David just said, as opposed to get this coverage in network? And by the way, that creates a much bigger financial barrier to people, not only those who unfortunately have to pay all cash, but if you're paying out of network, you're paying more. So the idea of parity was to eliminate these disparities, these inequalities. And we made it very clear in the law, inpatient in network, outpatient in network, inpatient out of network, outpatient out of network, equality in terms of pharmacy benefits, and of course, emergency room benefits. As Dan said, we do not have an emergency response system. It's commensurate with what we expect from the physical health system. And by the way, cancer drugs get paid for automatically. You don't have to go through step therapy the way you do with mental health. There is just a cascading sense of discrimination when it comes to treating the brain like any other organ of the body. And so, this is why we have been working with the Biden administration has been really out in front on this. And again, payers are pushing back hard, which is why advocates and consumers, and thank you, NAMI, really need to step up. Now, all of a sudden at the 11th hour, payers are saying, oh, we can't live with this, we can't live with that. They've had 15 years. They said, oh, well, there's not enough clarity. They've had 15 years to provide that clarity. Oh, they don't know what this means. They've had 15 years to sort this out. And at the 11th hour, they're Chicken Little saying the sky is going to fall, when they have to take the ownership for their lack of accountability and the fact that they've never put the urgency behind this. And as David said, they blame psychiatrists and other providers when they're the ones who haven't paid them a commensurate wage. And then we wonder why people don't go into this space. But going back to my original point, what's the point of parity? It's not just to get the medical care on par, but it's to put the pressure on the payers to finally come up with a new system. Because those of us in recovery know that, the medical piece is just one piece of the most optimal form of care. And as I mentioned, the clubhouse model for people with severe and persistent mental illness, combined with supportive housing for people with addiction, having sober housing paid for. But by the way, some of the evidence-based interventions like sober housing, like clubhouse, are not reimbursed under insurance. We need to change that. That's only going to happen if payers feel the pressure to finally do something about this. And if they're going to put money in it, we in the advocacy community want to make sure that money goes to where it's going to make the biggest difference in outcomes. And the outcomes are open and shut, solid, go to the bank with them. So no one can say, oh, we don't know whether this makes a difference. Yes, we do. We have the evidence. We have the science. Now we need people to listen to that and take our recommendations.
Thank you. Clearly, this has been a, if not lifelong, decades-long passion for you, and appreciate your leadership, because I know we wouldn't even have the opportunity to provide additional regulations around this bill if you had not led the fight for this bill back in the 2000s. So thank you for continuing to lead on this and push this community forward. Assistant Secretary, I'd love to go to you, because we've heard from everyone about this opportunity, this point in time. And I'm wondering if you could tell us a little bit about why the Department of Labor, along with Health and Human Services and Department of Treasury, felt it was important to look at the parity regulations. What is included in it? What would it change? Why was it important to do this now?
There's a lot to that, and many different pieces of this, but a few of the things are, number one, as Patrick said, 15 years is too long for anyone to be looking for some kind of real relief. So to have a law passed and 15 years later, none of us can say that we've gotten very far in really achieving mental health parity. And I think the first thing is that Congress, at the end of 2020, came out with a law and said basically to the Departments of Labor and Health and Human Services and Treasury that you all are not doing enough. And we're going to pass a law that says that you all need to be looking more closely at these non-quantitative treatment limitations specifically. And so there was a law that went into effect at that time and required that the different departments and that the Department of Labor specifically do these comparative analyses of non-quantitative treatment limitations with respect to plans, and that plans have those analyses ready to produce to the department upon request by February of 2021, so that when we were to go in there and ask for that comparison, we could see how plans were treating and covering mental health and substance use disorders as compared to medical and surgical conditions. At that time, departments were also each given some funding to try to really be able to put that extra effort into enforcing the PIA. And so we took that at the department as a real charge to move forward, both with enforcement and with regulation. This regulation, the proposed regulation that came out, it's interesting in many senses, but it's interesting for me in the sense that it is so driven by enforcement experience and by what our investigators and the people who are moving forward with these MPIA cases are seeing, what their challenges are, what the differences are. And so it's a real learned experience and on our part coming forward with this. So it is not theoretical and we don't know exactly how this would work. My investigators knew what they needed in order to be able to really enforce MPIA. And so we have never had so many people, both on the outreach side and the enforcement side. I mean, just a complete group effort in contributing to what we need to be able to properly enforce these laws and protect people that need these protections. So that, I think, is one thing as far as like where we're coming from and why now. As far as what we're trying to do, we have these proposed regulations, and with this proposal, we started out with something that I also thought was pretty interesting. It seems pretty basic, but it gives you an idea of just where things are. We wanted to level set the conversation and say, like, what is the purpose of this rule? That if you are trying to figure out what your rights are or your health plan, trying to figure out how to comply with these rules, what is something that you should always come back to? And so that's why in these proposed regulations, we have a purpose section. And the purpose section is very simple. simple in reading, but not so simple in getting compliance with. But simply to say that a person who is trying to obtain coverage for mental health and substance use disorders should not face barriers that are more restrictive than what they would face for medical and surgical coverage. Again, seems like a very basic concept, but it's something that I think we lose sight of. And when we talk of all of these different challenges and issues that people are facing, this issue of provider shortages, just think about, like, why are we facing provider shortages? It's this complete, like, circular, issue where if you're not going to treat providers in the right way because you're going to make them jump through a million hoops to get paid, you're not going to pay them what they're worth, you're just going to make it, really unrealistic and a bad experience to be a mental health provider, then why does anyone get into this occupation to begin with? So that's the first thing that we did. We also, in the proposed regulations, provided very specific examples to make sure that plans and issuers could not use more restrictive prior authorization requirements, medical management techniques for mental health and substance use disorder than they do for medical and surgical treatments, that network adequacy standards are addressed and figured out, and also looking at outcomes, as Patrick mentioned, because outcomes, if we have lots of pretty rules that look very nice and we can all pat ourselves on the back about, but at the end of the day, the outcomes are not different, then what are we doing this all for? So we made sure to cover all of those things, and also to focus really hard on determining out-of-network reimbursement rates for mental health and substance use disorder benefits. So looking at all of these things that are not the kind of in-your-face, how many visits can you get to go to and how much will we pay per visit, but the items that are beneath the surface and the ways in which the lack of parity and the barriers are really occurring. So focusing on all of that. With respect to outcomes, in the proposed regulations, we require plans to, again, collect and evaluate outcomes data that they have and take actions to make sure that they are working to make material differences in access to care. Because again, if we have these lovely rules, we can, they'll look very pretty on my bookcase one day or, in my computer, but they won't be doing any good for anyone. So that's something that's very important. Again, just focusing on material differences in access and making sure that we are addressing that. We have also, in the proposed regulations, looked to codify requirements that plans conduct the comparative analyses that are required by law, and looking at things like, again, network adequacy, reimbursement rates, prior authorizations. In all of my meetings with care providers and advocates over the 1.5 years that I've been here just now, that's just all that I keep hearing about again and again and again, that that is a huge issue where the problems lie. So we're very focused on that in the regulations. One of the main things that we try to do is provide example after example after example, and examples of not only instances that would violate the rule, but also instances, fact patterns that would comply with the rule. Because we kept hearing from folks, this is impossible. No, it's a test that no one can pass. Everyone, if everyone has tried to put in their comparative analysis and it's never right, that's the fault with the test. It's not a fault with the test taker. And we just refused to take that as an answer. And we saw people that were getting good grades on these tests, maybe not the first time around. They might have needed a little tutoring. They might have needed a little bit of extra help and some, nudging along the way, some examples, but they got there. And so we wanted to highlight those and really just put forward to people that it can be done. It's not impossible. And I feel like all that we hear is that it's impossible. You can't do it. We can't get there. And so that was something that was very important to me personally, that we put in examples of these people made it work, so that you can show that 15 years later, this is a place that we can get to. It's not a place it's an impossible place to get to. So those are all kind of like the very high level pieces of it, but that gives you an idea of sort of where we're trying to get to, but very like data focused and experience based.
The payers have kind of brought it on themselves. I mean, we've seen recently, as David knows, this Witt versus United case, which the federal court found that, the largest insurer in this country was literally making up their medical management criteria, as opposed to using generally accepted standards of care to determine the type of care someone needed, the level of care, the length of that care, and so forth. When you have payers completely ignoring what the science says is the best way to treat a particular diagnosis, it's hard for them to argue that somehow we are being over zealous in our efforts to try to see that there's some basic equity restored to the system. I firmly believe that if payers do the next right thing, as we're taught in recovery, and basically align the clinical standards of care as backed up by medical science to the fact pattern, as the secretary mentioned, they're going to be fine. They're going to be fine. It's, that is going to be the pressure, though, if they're not aligning the fact pattern, if they're not using generally accepted standards of care, if they are not doing things that's the next right thing, best faith effort to comply, we're going to know it. So the administration is very busy. It's lots to do. The notion that they're going to be going after everybody, when frankly, unfortunately, there's enough bad actors out there right now to keep everyone busy. We can have this done right if payers really lean into doing what is possible in terms of trying to make up this historic gap in services, which frankly, they have been part of the problem, but so hasn't the whole system. So they shouldn't take this personally. They need to lean in like everyone else to try to fix the system. And by the way, that means providers too. We're going to need to have providers ensure that they're using evidence-based therapies. Unfortunately, many don't. So while we want to make sure they get paid appropriately, we also need to make sure that what they provide is evidence-based themselves. So there's accountability on all of our parts to move forward and do so on behalf of the community that's listening to this and are consumers and their families out there.
Yeah, thank you for that. I'm very struck, Assistant Secretary. You are trying to set up payers to be successful, to successfully comply, but the focus on outcomes is so vital. That's why we're all doing the work that we do. We want to help people. We want to get people connected to care. Dan, David, any reaction to what the Assistant Secretary brought up? What, would love to hear. What's the reaction of the mental health community to these proposals? What difference do you think it'll make in the lives of the people that we all serve?
Want to see them sooner than later. We're very appreciative that the administration is working very assertively and aggressively to actually implement and inspect what we expect and actually change some of this from the standpoint of our payers. And in our community, lived experience, we need it yesterday. So it's like we're so grateful. And the thing about it, we come at it, NAMI, from the standpoint of like all of us, we are parents, we are uncles, aunts, godparents. We walk in the shoes of navigating this ourselves. And so we want it yesterday. So we're very appreciative of what the administration is doing and what Assistant Secretary Gomez is doing in her leadership and DBSA. We just as a point of information, our sense of urgency is yesterday. It's so amazing to me, just as a parent. Patrick brought up cardiovascular disease. It's very interesting. As I went to the cardiologist last week, there was no issue about the paperwork. But if I went to go for any type of mental health assessment, it's a very good possibility. One, I wouldn't get an appointment. Two, the administrative burden of the paperwork, it would be, I'm sorry, Mr. Gillison, but this has been denied. There's so much here that we can fix if we walk in the shoes of our access as a parent or as an individual with lived experience trying to access the services ourselves. So we're very appreciative of what the administration is doing and the direction we're taking. And my thing, Hannah, answering your question is yesterday. And last thing I'll say is that David mentioned the RTI report. I also want to mention the report that just came out from the Morehouse College of Medicine and Satcher Health Leadership Institute, which is the second one, the economic burden of mental health equities in the United States. It's almost like that statement, pay me now, pay me later. There's an opportunity for us to get this right. And the information in here talks about the cost in 2044 to the United States economy if we don't do some things right now. We have the opportunity, and it takes leadership, tone, and execution, and it needs incredible support. So Hannah, I know you're like, okay, Dan, narrow down that one. So I'll stop there. But that's the passion from our community as individuals with lived experience who have turned their pain into purpose.
You know, I've had many of my Republican colleagues say to me that the payers, by denying this, are pushing this over on the taxpayer. So Republicans don't want high tax rates. Well, guess what? Taxpayers are subsidizing the current payer community, because if they can take all of their most expensive patients and push them off onto the taxpayer, then that's not them being smart business. That's just them shirking their responsibility. So over to you, David.
We're so grateful for the leadership of the Biden administration and EPSA, and specifically to you, Assistant Secretary Gomez, for these proposed parity rules, which we hope are finalized, as Dan said yesterday. There's enormous support in the mental health community. I think over 9,500 comments were submitted to the proposed rules. And the vast majority, it's getting up towards 100% of the comments were in strong support of the proposed rules. I sometimes look at what I think are kind of threshold questions of whether insurers are even coming close to what they need to be doing and taking these issues seriously. And unfortunately, I don't think we're there. You look at things like for young people with early psychosis, there is something called coordinated specialty care. Is the evidence-based intervention that has been highly studied in close to 100 clinical trials that were organized by the National Institute on Mental Health, and they're simply not covered by commercial insurance, which is really outrageous if you think about a young person experiencing the first episode of psychosis, which is really terrifying, for a young person, having to go through that. If we have a young person who, has symptoms of type 1 diabetes for the first time, they get the services they need without question, and those are covered. So the fact that we can't do this and the insurers aren't doing it really just shows, in many cases, a lack of bad faith, to be quite honest. And another area where this is a threshold question is coverage of emergency services for mobile crisis response as part of our crisis response system. All insurers across the country pay for ambulance and EMS transport as part of their health coverage. They're not paying for mobile crisis response services, and they could easily do that, but there are all sorts of excuses why they can't. The irony, though, is that there's a strong business case for the insurers to be covering behavioral health more appropriately. Between 2 and 6 times higher healthcare costs for individuals with a behavioral health diagnosis than for individuals without such a diagnosis. And so by not investing in behavioral health, they're actually you're really increasing overall healthcare costs in a way that is detrimental to their bottom line, their profitability as insurers. And that's why recently in the last couple of years, there was a report by Moody's Investor Service actually recommending that for insurers to become more profitable, they should invest in behavioral health, which just shows there's the irony here that they're not doing what is in their own interest to increase their own profitability. And it's because they're too focused on short-term cost reduction and that short-term bottom line, and not taking advantage of these savings on the physical health side that they could get. So certainly, I think it's critical that the final rules come forward soon. And again, we're grateful to EPSA for all your work.
If I could also just, thank you everyone for your comments. And I cannot possibly take credit for this because the people on my team and their passion for this role is just extraordinary. This is way more than a drafting exercise. And anyone on this call who knows the folks that I speak of, I am so fortunate to be part of this administration. The president himself has talked about mental health in his State of the Union addresses and of the impact of mental health on his own life. So we are so fortunate to have that, and we are working very hard to get this rule done, but to do it right. And so I am hoping that folks will see it soon, and that it'll be a great move forward. I wanted to just point out, though, because some people who may not know my background, I came into this position after working almost 30 years representing plan sponsors. And, it's not as if everyone is looking to, do things the wrong way, but it's not working hard enough to think about how to do it the right way. And I will tell you that, you know, Patrick was my first meeting that happened to happen. The first meeting that I walked out of was a meeting with plan sponsors talking about mental health parity, and folks telling me that there wasn't enough guidance and they couldn't possibly do this and they don't know how to do it. And I just was so frustrated by the responses, and my meetings with them, unfortunately, continue to be coming from a can't do attitude rather than trying to really figure out how to do this. And, you know, I've often told people, you know, stop telling me how you can't do this or complaining about how this is hard. Come to me with some kind of solution, even if you can come to me and say, we can fix this much of it. But you know, there is a real battle against moving forward, which I quite frankly don't understand, because if you know, don't come at it from a moral, personal perspective, which should be enough, or, you know, dollar perspective, as Patrick's mentioned, as David's mentioned, the amount of physical ailments that accompany people who have mental health disorders and other costs to society, not being able to hold down a job, days lost at work. I mean, we have a whole separate initiative, separate but together initiative at the Department of Labor on mental health at work, and trying to support employers and employees on helping their employees and fellow employees on making it through the workday. Aside from the whole mental health parity regulations, we are trying to support workers and the workforce in that area, because until we're doing that and really making a meaningful contribution to trying to help people, and make this part of any other type of ailment that that, you know, folks have to deal with, we're not going to get anywhere. But I do, you know, have hope that the message is getting through. So so we'll see, but
Yeah.
no fear. I don't take this easily from people. They
Yeah,
come
no,
in.
your points, Madam Secretary, right on. If the payers would be proactive as opposed to reactive, I mean, we know in this community the kinds of things we want. You know, why aren't they coming to the table and saying, let's help you, federal government, address the workforce pipeline? You know, they look at things in a vacuum. This is a comprehensive set of challenges. If they were helping overall, you know, there'd just be a lot less of this tension where, you know, they don't feel like they're being heard and that they're not willing to step up and help overall. So this is a system-wide problem. They own a part of it, but also a much bigger part, which is tying in all these social drivers, Dan, housing, fixing the justice-involved system, trying to get the human services, and working, as the Secretary said, with the business community, because the savings come not just from total cost of care, but also come with greater productivity and reduction in absenteeism. And so there's so much to be had if we're more kind of proactive. And that's what we need everyone to be going forward, including the federal government. And we have work to do everywhere in the system.
Yeah, and I'm struck by kind of the positivity of what we can accomplish when we work together. You know, Assistant Secretary, you talked about can-do attitude. What can we do? What can we make happen? And being proactive. So, you know, I could talk to the four of you all day, but unfortunately we're coming up on time. So I want to give you all a chance for just last thoughts. As again, we mark Mental Health Month in May. What are your hopes for the future? Where do you want this community to go? And what do you want for people affected by mental health and substance use conditions when we look 1 year, 5 years, 10 years from now? Dan, I'm going to go to you first.
Thank you, Hannah. First of all, demystify mental health and have this conversation that we're having today across many platforms and many tables. And also, we want to see some real movement in terms of what Patrick said, proactive movement on parity versus having to react. We have a podcast called Hope Starts With Us. And the reason for hope starts with us is because we are hopeful for the future, and it's one of our values, and one of our other values is inclusiveness. So what we want to see is all communities supported in terms of mental health, and we're very challenged by that opportunity, and see that we've got young people that are coming to the table now that want change as well. And they are more aggressive in terms of they're not going to necessarily sit and wait. They're even more willing to share their mental challenges as they go into the workplace. We see this evolution coming, and what gives us some real hope is all the new voices that are coming to the table. And then this collective voice, if we construct this almost like a quilt, and each of us being a patch on that quilt with this one thread through it being mental health and parity, we can construct something here that we can change the current situation. It will take work, but I think we can do it as a collective.
Thanks, Dan.
Mm-hmm.
Congressman, any last thoughts?
No, just that we need to have this alignment for progress. So I want to thank NAMI for their leadership, Dan. We need to come together as a community to really map out what we expect from payers, from the government, both federal, state, and local, and from employers, and for the rest of the medical system. We just have to do a really good job, like other special interest groups do, where they curate all of their recommendations and then hold politicians accountable to those recommendations. And NAMI having the biggest reach out there, we have a ready-made army ready to push all this. So I'm excited to work with NAMI and us move all of this forward by getting organized and prepared so that we can make a difference.
Thank you for that. And yeah, it will take all of us, and we are better together when we do that work together. David, I'd love to hear, what your hopes are for the future.
Yeah, my hope is that we'll continue to make progress in really setting up the sustainable financing that is necessary to fund all the important work that NAMI, the Kennedy Forum, and all the other advocacy groups are pushing for, to allow us to build these systems to meet Americans' mental health needs. Because without sustainable funding, if we're just relying on block grants and grants from philanthropic organizations, we can't really build a system on that, and we can't scale services to meet needs, and those line items, when the next downturn comes, are really at risk. So having those sustainable finance mechanisms is really critical, and shows that we're really making mental health a priority. Because if we don't have those in place, then honestly, we aren't making mental health the priority that it has to be. So grateful to EBSA and Assistant Secretary Gomez and Patrick and Dan. Hannah, thanks so much. I really appreciate the opportunity.
Thank you, David. And Assistant Secretary Gomez, I'm going to let you have the last word. How do you want to close out our conversation on Mental Health Month, and what are your hopes for the future?
Well, I want to first say thank you so much for having me here. And again, it's just such an honor for me to be able to be in this position at this really important time. A couple of hopes that I have. I'll start with the funding conversation. We are a very small agency, and we were given funding a few years ago to initiate more of a push towards mental health parity, and that funding is expiring at the end of this year. So hopefully those folks in Congress who really put a priority and say mental health is important will remember that is set to expire at the end of this year, because we do not want to stop what we're doing right now. I'll also say on some of the comments that my colleagues on this call made, this is a broken system, and we are going to have to work together to make things work in the future. So many people have lost trust in so many ways, and we're all going to have to gain trust, whether you're a patient, whether you're a family member, whether you're a provider, whether you're a plan, whether you're an advocate. We're going to have to just work together and say, I'm willing to kind of jump back in and, do my part to try to help make this work. And then as far as hopes, I hope that in someday in the not too distant future that people can realize that, one's anxiety is going to affect their lives in a way more challenging way lots of times than a bad shoulder, or, having a bipolar disorder or an addiction affects your daily life in way more. And all illnesses are very tough to deal with, but we have to get to a point where we're at least acknowledging things to be equal, and we're not there. But I hope in a few years, I'll be able to come and tell you that that I went to a college graduation and they were all proudly displaying their mental health therapy cords, and it wasn't a secret society, because that's where we should be.
Yes, let's hope that that is the future we have for our kids, and hopefully for all of us in the not too distant future to come. So thank you all. I hope we can get this group back together to continue to talk about it, but I want to thank each of you for your compassion and your passion around this to help all people affected by mental health and substance use conditions. We have a lot of work to do, but as we work together, it gives me a lot of hope that we're on the same page and we're rowing in the same direction. And we've seen so much change in just the last few years. So excited to see what comes. Wishing everyone a happy and healthy mental health month. Thank you.